Dr. Fox and I will email you when you're able to upload the exam. And incidentally, I'm sure you guys got the email, but I discovered an error in the exam when I was reviewing it with another student. And so we made those adjustments and fixed the exam scores. We had fixed one problem, but then apparently there was another one. So anyway, it happens. But it was to pretty much everybody's benefit. So that's always a good thing. So the exam will be 30 questions. It's going to be very similar to what you've experienced before. I'm not quite sure yet how many bonus questions we'll have. There'll be either like 3 or 5. Again, whatever Dr. Fox lets me do. She's a little bit stricter than I am. So, and then we'll cover topics from, I guess, colon cancer, lung cancer, B-cell malignancies, myeloid malignancies, and then the ethics. And with the ethics, it's just going to be kind of similar questions as I asked in the IRAT. I may show a couple of Kaplan-Meier curves, and I want you to be able to tell me like which drug performs better. And these are things that hopefully you should be very comfortable with. And if you're not, reach out to me and I will help you read a Kaplan-Meier curve because that is essential. It's really important. It's part of what we do. So, and then there may be a couple of topics that maybe get an additional question or one that maybe gets less, just again, depending on how much time and emphasis we spent on something, because I don't want to throw anything out and make it confusing for you guys. So, all right, I'm going to start recording. Let's see. And I apologize for all the noise in the background. Apparently today's, I don't know what's happening out there. Maybe it's the end of the world. There's a lot of beeping. Okay. Oops, I have to be the host. Okay, hang on a second. You guys excited about being done, pretty much? I'm excited for you.
It's kind of surreal how today's like the last day that we'll have didactics.
Yes, it's super exciting. And it's definitely a really weird transition point for all of you, but you've earned it. You guys have worked your butts off for the last 3 years. You deserve this. Actually, way longer than that because you had to get into pharmacy school. So this is a culmination of many years of hard work, of not having confidence, feeling like, oh my God, everybody is smarter than you. And you know what? The reality is that's true and that's okay. There's always going to be somebody smarter than you, and that doesn't matter. You just got to do your best all the time. All right. Do or do not. There is no try, right? And I know you're not, some of you are like, I'm not ready, but you will be. You will be. I feel like that every day when I come to teach, so it's okay. We all share it. And I appreciate you guys being really sweet. You've been very patient with me too. I know technology has not always been easy, but I really appreciate, you guys participating when you can, and also letting me know when you're having challenges and when your classmates are having challenges. Again, that's what changed the testing time. So just knowing that people were having a hard time at home was really important. And Karen's done a really great job of advocating for your class too. So I want to thank her, and I hope you guys appreciate everything that she's done too, because it's been really important for your class. So awesome. All right. Well, thank you guys for, yes, she is the MVP. Thank you guys for everything. And I will get started now. And also remember, this is like not the end. You can always contact me if you need something. So you're nervous about rotations, whatever it is, just make sure that you reach out to me and I'll help you with whatever I can help you with. Or if I can't help you, I'll direct you to the person who can. All right. Recording. All right. We're live. Okay. So, starting with colon cancer, you're going to see a lot of questions that are very similar and in some cases may be identical to the IRAC questions, because those are, very helpful in terms of concepts. So make sure that you understand for colon cancer, some of the drug specific information about like dabrafenib and trametinib, as well as like when we combine the two drugs, which obviously we have to for that for the mutations, and then also knowing when we test for like the KRAS, NRAS, BRAF mutations. So remembering that we only test them in stage 4, but that we test for the deficient mismatch repair and the MSI high or low, whatever their MSI status is, from all the stages, right? Because it's predictive for some of the responses to chemotherapy. So make sure you know when these tests are appropriate. And then it's really important for you to know the toxicities associated with FOLFOX, FOLFOXIRI, right? So FOLFOXIRI is a combination of 5-FU and leucovorin and oxaliplatin and irinotecan. Super toxic regimen, right? So it's really important to know kind of what particular side effects may occur with the different drugs. Now, I'm not going to be like, tell me if irinotecan or oxaliplatin are, more or less bone marrow suppressing. No. I want you to remember the things that are really important about each of the drugs, right? So oxaliplatin is a moderate emetogen. So is irinotecan. They can both be highly emetogenic in some patients. Irinotecan causes a ton of diarrhea. I ran to the can, remember? Oxaliplatin causes that awful laryngospasm when people do, drink something cold, right? So people can have neuropathies associated with cold sensitivity. Let's see what else here. And make sure you know the mechanisms of action of the chemos that we talked about and the drugs that we talked about in colon cancer, right? So we didn't talk about that many chemotherapies, but so, know that 5-FU is an antimetabolite and what is aloxatin or oxaliplatin, irinotecan, et cetera. Also make sure that you know brand and generics. That's very, very important. Because if you can't recognize the brand, then you won't know what the drug is. Okay? And then we talked about VEGF inhibitors being used in ovarian cancer, and for bevacizumab, there's like a specific requirement for holding prior to surgery and after surgery. It's a little bit different for colon cancer, so I want to make sure that you know the difference in terms of timing, because that can be really important for a patient for receiving proper care. And some of the appropriate pre-medications needed for things like FOLFIRI or FOLFOX, right? So we are concerned about emesis, but in the case of irinotecan, we worry that the diarrhea and cramping can be caused because irinotecan looks a lot like acetylcholine, right? So it has cholinergic activity. So I want you to be able to recognize what we give to help stop that activity in the stomach. And then being able to match ADRs with various drugs that we talked about, like major toxicities. Again, I'm not going into the weeds. Things like we know that VEGF inhibitors are bad for wound healing, and they can cause, protein spilling into the urine and like all kinds of stuff, right? So the major stuff, I'm not going to be, again, mincing like, hairs with you about, does this one cause more of this or whatever? Like it'll be extremely clear, okay? Because you could probably look on the internet and find that every single one of these drugs shares one of the same kinds of toxicities. And I'm not out to trick you. So only the stuff we talked about. All right, so shifting gears to lung cancer, really going to be important for you to know those NIBs, right? So we talked about a lot of NIBs. We talked about the ones that are used for the ALK mutations. We talked about the ones that are used for the EGFR mutations. Definitely need to know some of the major toxicities. Again, we talked about rhabdomyolysis for one of them. We talked about some of the ocular toxicities, thyroid toxicities, pulmonary toxicities, etc. Again, it'll be very, very obvious. So just make sure that you recognize kind of the major toxicities. Also would like you to be able to recognize, again, like we did in the IRAT, some of the different risk factors associated with lung cancer, right? So who is more likely to develop lung cancer, and can you figure out what their risk is? And then, of course, along with that, make sure that you remember the lung cancer screening, right? Because now that Medicare has approved it, more and more patients are asking about it, which is great. But unfortunately, a lot of primary care physicians may not necessarily realize that it's available or advocate it for their patients who smoke. The colon cancer screening recommendations have been out for much longer, PSA, things like that. So that's more kind of reflexive for providers, but not necessarily for lung cancer screening. So that's important. And we also know that there are health disparities for patients who have lung cancer. Often providers perceive patients as smoking and choosing to smoke and not necessarily giving them access to all the care that they need and that they should be getting. So that's an important one. We talked a little bit about etoposide. Sorry, my leg's falling asleep, so I'm moving my chair. We talked a little bit about etoposide for small cell lung cancer. So I want you to be able to understand and remember some of the different toxicities associated with it, especially administration toxicities, because that's a very important one. So we have limitations for how quickly we can run the medication, and it's important for you to be able to recognize why. And then also know the immunogenicity risk of the different chemos we talked about. So there's really not a whole lot of extra stuff, right? We talked about the platinums, we know that immunogenicity, we've talked about the taxanes, we know those. And then there are a couple of other drugs, including like etoposide and some of the other potential chemos that we talked about as well, like navalbine or vinorelbine, which is a vinca. So I want you to be able to select an appropriate antiemetic regimen based on, kind of what we've talked about. And the reason I keep carrying this theme through for each of the exams, even though I'm sure you would like to be done with it, is that this is really an essential function of being a pharmacist. It's one of the most common kinds of interventions we might actually get involved with patients. All right. And then also we talked about clinical presentations of lung cancer, both pulmonary and extrapulmonary. So there are some complications that can be really dangerous. We talked about one called SVC, and it's superior vena cava syndrome, where if a tumor is big enough, it may compress the vena cava and actually cause blood to back up into the heart and into the neck, and can cause really serious problems. That's considered an oncologic emergency. We talked about some other things too, about hypercalcemia and, just some of the typical presentations that can happen for patients who have lung cancer. So just be familiar with those, because lung cancer is unfortunately, common cause of death among cancer patients. All right. And then shifting to B cell malignancies. So being able to identify some of the pathologic manifestations between like non-Hodgkin lymphoma and Hodgkin lymphoma, and then kind of being able to recognize one of the major therapies that we give for Hodgkin lymphoma and non-Hodgkin lymphoma. So we kind of talked about that quite a bit. We actually did a lot of activities around, treating Hodgkin lymphoma. And then we also talked about, just for CLL, a couple of the drugs and some of the toxicities that we want to monitor for. Again, you'll see a very similar question to what we had in the IRAT. And make sure that you also really know rituximab well, because again, this is a commonly used drug in a number of different hematological malignancies. So I want you to be familiar with that drug. And you'll see it for a whole host of other reasons too. We use it for arthritis. We use it for ITP. We use it for all kinds of things. Uveitis as well. All right. And then important to know some facts about ABVD, right? So what are the different drugs in that regimen, and some important information about, bleomycin, for example. Definitely need to know the cumulative lifetime dose of bleo. There are really only a few drugs that we use that actually have a cumulative lifetime dose, and this is really an important one. Same thing goes for doxorubicin. And I want you to be able to recognize when drugs are irritants or vesicants within that regimen. That's really important. That determines how we give that drug or those drugs, right? So if they're a vesicant, we're going to try and not give them peripherally. We're going to try and give them into a large vein to help dilute it quickly, so that patients, if they have it leak out, it's not necessarily going to cause a lot of tissue damage. And then we talked about a few other things about bleo. So besides the pulmonary toxicity, we talked about like the anaphylactoid reactions and kind of how we approach preventing that. So make sure that you know those kinds of things. And then we talked about RCHOP, so make sure you know which parts of the regimen are active. And also, again, some drug information about some of the drugs that are in that regimen. And also being able to identify some of the clinical presentations of a patient maybe whose CLL might be transforming, or some commonly associated symptoms with lymphomas, right? So we talked about B-type symptoms and constitutional symptoms versus some of the more leukemia-type symptoms, which is like the bruising, the bleeding, easy infections, things like that. And then also, we didn't talk about this in great detail, but I did talk about it on a slide when it comes to management of tumor lysis syndrome. So being able to understand what that means, right? So you've got high cell turnover. You have a whole bunch of cells die. They dump tons of different solutes into the periphery. You get increases of potassium and uric acid and things like that. So I mentioned some of the different ways in which we manage it. So again, I'm not going to ask you like specifically give me drugs and doses. I just want you to have a general understanding of, we use things like hydration. We might give resburicase, like talked a little bit about allopurinol, but there's some limitations with allopurinol. It doesn't prevent you from, so it prevents you from making more uric acid, but it doesn't get rid of the uric acid you already have, right? So that's why we prefer to use resburicase. So just again, make sure you kind of look through that slide and conceptually understand it. As this is a common side effect of some of the drugs that we use for lymphomas or CLLs patients, but also can just happen when patients have really bulky disease, among lymphoma patients especially. Shifting to myeloid malignancies, I talked about a particular drug that's very flammable. That's important to know. It's important to know because if you have that in your pharmacy, you definitely want to make sure that nobody's smoking in the pharmacy. I mean, I would hope that that would never happen anyway. But believe it or not, there are a number of combustible drugs, and this is one of them. And then talking about MDS, we kind of discussed this in our IRAT today. I definitely want you to know, again, for patients who have that deletion mutation, what's kind of a first line or appropriate therapy. And I didn't go into great detail about Revlimid or lenalidomide, but just being able to recognize that for some of the mutations, that's really important. And in many cases is able to bypass patients receiving much more aggressive therapies. All right. And there's survival attached to it as well, survival data. And we talked about what kinds of hematological disorders might actually lead to development of AML. So it's going to be important for you to recognize that. And we also talked about intrathecal installation of, methotrexate and cytarabine. It's going to be important for you to recognize kind of like when patients may be having kind of CNS symptoms versus when we give them drugs like Ara-C or methotrexate. Sometimes those can cause neurotoxicity. So being able to recognize that, again, cytarabine can cause all kinds of neurotoxicities, and methotrexate as well. All right. So really broadly, because we don't really cover stem cell transplantation in great depth because it's beyond the scope of the class, but it is important for you to kind of understand some of the treatment goals that we have for AML. So, there's one particular slide where we talk about like induction therapy, right? And then consolidation. And then either if you're able to go into a stem cell transplant or maybe, we're not able to continue therapy for patients, being able to kind of have a sense of that slide and understand, again, what the sort of general pathway might be for an AML patient. And then also, very, very generally understanding a little bit about the mechanics of how we do a stem cell transplant. So if we're doing an autologous, right, we're harvesting your cells. Allogeneic, we're having somebody donate. So being able to recognize those terms, and then I think I had one slide of just like kind of the pathway of what happens to a person who's receiving a transplant. And that's important for you to know so that when a patient says to you, I had a stem cell transplant, essentially kind of what they had to do to achieve that remission or the experiences that they went through. That's really incredibly important because that can often, stem cell transplants can often result in permanent liver or kidney injuries. And so that may really change the kinds of comorbidities that a patient presents with. So it's important for you to know about that. And then imatinib, we talked a little bit about imatinib and dasatinib and how dasatinib can be used, or Sprycel can be used, right, to overcome resistance to imatinib. And those are really common drugs that are used in CML. And I'd like you to know a little bit about some of the major ADRs attached to them as well. And then that's it for like clinical questions. So in terms of the ethics, again, I'm going to focus on pretty much the questions that I asked you in the IRAT, and then maybe add a Kaplan-Meier curve or a couple of pieces of data for you to just kind of look at and, tell me just by looking at it, which drug may be more efficacious or maybe not. So I really do want you to be able to identify that stuff. And again, if you need help with Kaplan-Meier curves or reading any of those kinds of biostats, please let me know. We've got time between now and Thursday. You can set up an appointment with me and I can help alleviate some of the stress. But really, it's just generally about like, do you see that curve separate? And if it separates, then that normally means that the drug on top is better than the drug on the bottom. If they cross over, then it's probably, at some point, it's not going to be efficacious. And in fact, could have a worse outcome and could mean safety implications. So nothing more than that, I promise. Okay. So that's it. So I have to finish filling out the rest of like some of the wording. Again, I want to make sure that my exhausted brain didn't write the test. So, but that's what I'm going to ask you guys. So nothing surprising, nothing crazy. And then the bonus questions, like if you get a question, you're like, what the hell is that? It's probably a bonus question. So don't panic. Keep calm and chive on.
How many
Okay.
questions
Yeah.
were you thinking total, approximately?
So 30 questions for the exam portion, and then between 3 and 5 bonus questions.
Thank you.
Yeah, of course. Okay, so before I stop our time together today, do you have any other questions?
Dr. Leva, for this MDS lecture that you just went over, did you state what drug was we wanted to avoid putting near flames in the video lecture?
I did, yes.
Okay. I probably just missed it then. I'll have to go back.
Yeah, no, it's in the, it's probably in the AML. Actually, that's a good question because we use it for B cell and myeloid malignancy. So let me just make sure that. Sorry. It's in.
Yeah, it was for Hodgkin's, right?
Yeah, it is, but we use it in myeloid malignancies as well.
Okay, I found it. Thank you.
Excellent. Yeah. It all runs together now. After weeks of this, you're like, yeah, I know. We're tired of it too. Okay. All right. So before we go, again, I cannot convey to you how much of a pleasure it's been to be in this position with you for the last few weeks. And I hope that despite a less than optimal learning environment, that you've been able to kind of get a sense of oncology and sort of what oncology pharmacists might do and the kind of trouble we can cause, generally speaking. And that maybe some of you have an interest now, or at very least, your curiosity was satisfied. So again, it's really been a pleasure, and I wish you all well. And I hope that you know that we'll figure out everything when it comes to your appies. It will get solved. It may not be awesome. It might not be what you expected or what you anticipated or even what you want. And, even though I can't control it, I do feel a deep empathy for your class. This is a very difficult time to be transitioning into the experiential part. I hope that when you do start, or for those of you who are working now, that you stay safe and that you're able to be, personally protected from COVID. And again, if you need anything at all, please feel free to contact me. And thank you for letting me teach you guys for the last few weeks. I appreciate it. So.
Thank you so much.
Thank you.
Thank you for making it such an approachable class.
Oh, good. I'm glad.
Yeah, a lot of my friends back east are talking about like how their onco professors are just giving them block exams with like 10 plus topics at one time.
Yeah, I have bad words to say for those professors. It's not fair. And you know what? It's unnecessary. You're going to learn so much when you get into the real world. This is really only supposed to be a taste of oncology, and spark maybe more interest. So awesome. Well, I love your class. You guys are great. And I can't wait to have you on rotation. So awesome. All right. Well,
Dr. Leva, have a great day.
Thank you. You too. All right. So I'll email you guys about Sunday, the time, and we'll do the Teams meeting, the same link that I gave you guys for the office hours. And, we'll figure this out. Good luck.
Thank you so much.
All right. Thanks, guys. Bye.
Dr. Leva.
Yeah.
Do you know what CCI is? You know what CCI is doing in terms of appies